And I would like to thank also Nader, because you are the first, finally, American people participating in the European low-grade glioma. Thanks for coming and sharing, because the philosophy is very important too, and not just the technological issues. I'm sorry. Oh, thank you. Today, the goal is to speak about surgical management, but also the philosophical management of patients with low-grade glioma, and especially more and more incidental and diffuse low-grade glioma, because, as you know, we have now technological issues, as usual. You know me. Okay, now. What I should do? That these tumors are evolving. Nonetheless, I have the habit to show this slide, and every week in consultation, I will continue to follow some patients diagnosed in another department and telling to the patient that, in fact, the tumor was not stable. It works now? Yeah, it is. The problem is that this calculation of the growth rate is not done systematically, and then most of the time we have no this insight into the natural story of the disease in this patient at this moment. So definitely please take time to do multiple MRIs spaced by a couple of weeks if you are a little bit anxious because you have the feeling that the tumor could grow very quickly. But also please take into account this heterogeneity of the tumor, and it will be important, of course, when we would like to resect the tumor more completely and then earlier. Everything is linked. The second point is, as you know, we should be more objective regarding the neuropsychological assessment, and I'm very happy and would like to thank Dr. Rofes for his very important job on behalf of the Diffuse Low-Grade Glioma Network, because more and more we can demonstrate that it's possible to have more objective view concerning the quality of life of the patient before any treatment. And as you know, in 90% of cases, these patients already have some cognitive disturbances before not only the treatment, but sometimes, as I will show you, before the diagnosis also, I mean in incidental diffuse low-grade glioma themselves. I would like to thank also Fabien for this beautiful job. In fact, just 3 years ago, demonstrating that we started to understand why these patients have deficit, and it's not related to the location of the tumor, but related to the invasion of the connectivity. And it will be very important also to decide to treat patients with incidental diffuse low-grade glioma, because you should know exactly where you are, but also what you can induce as post-operative deficit, not related to a localizationist view, but in a holistic view of brain processing. Indeed, neuroplasticity exists, but we know also that the limitation of brain plasticity will induce this kind of deficit, but will induce finally seizures. In other words, when you have seizures, that means that brain plasticity already reached its limitation. And it's very important because that means that you have a risk to not be able to restore the brain or to see a perfect recovery following surgery, especially following surgery and radiotherapy, but not sometimes following chemotherapy. So that means that it's another argumentation in order to say we should treat earlier and, if possible, before epilepsy. What we know also is that if you do early radiotherapy, and we will have probably this discussion more and more due to the new recommendations according to some EANO criteria, we have a risk to induce cognitive disorders because we are not speaking about glioblastoma. The median survival now is longer and longer, and especially if we are doing surgery or treatment in incidental diffuse low-grade glioma patients. And then we should now try to anticipate what will happen in approximately 10 to 20 years following the diagnosis. And we know that if we are radiating this connectivity, we will induce cognitive disorders. So it's very important to explain that to the patient and not just to say everything will be okay within the next 5 years, of course. So why to continue wait-and-see attitude? And you will tell me, now we have understood. No, because 2 recent papers in Journal Neurosurgery and another paper also in Journal Neuro-Oncology said, we are not completely convinced about the exact role of early surgery. Very recently, in 2017, the problem is that in both papers, there are no evaluations of the extent of recession. So people continue to say, finally, surgery is not so efficient, but they continue to be subjective. That means that this introduction is we should speak the same language by being objective, to evaluate the volume, the kinetics, and the quality of life of the patient before any treatment. And it's never done. And nonetheless, they continue to publish, and the experts in this kind of journal can say, oh, this is a very nice paper. No, this is not a nice paper. So please be objective and do, of course, pre- and post-operative evaluation of the extent of recession, of the volume, and then extent of recession. Once again, it's never done in the vast majority of trials. So they are very happy when they published in Lancet Oncology or New England by telling, oh, we did a very important trials because prospective randomized. Yes, but you did not evaluate the most important treatment, the extent of recession, surgery itself. We didn't care, no interest. It was not demonstrated, blah, blah. Of course it's not demonstrated because they are not able to extract this kind of objective data with pre- and post-operative volumetric assessment based on the flare. So in fact, these trials demonstrated nothing. We know that suddenly if you have pre- and post-operative MRI in the recent literature, past 10 years approximately, then you have in all cases an impact on median survival. And I'm very happy to see that in the last paper by Iacola, not the classical one, now a famous paper in JAMA 5 years ago, but the new paper with a long-term follow-up definitely demonstrated, because it's a pseudo-randomized study, that the median survival, of course, is still 6 years with biopsy, but almost 15 years with early resection. It is demonstrated, but no one would like to accept that, speaking about the classical neuro-oncological, medical neuro-oncological society. I know that because I am in contact with them, and they will say, oh, it's not really a prospective trial with randomization. Of course, you cannot randomize for ethical issues. We have the proof, but they don't want to recognize that. And nonetheless, they will do a randomized trial without the evaluation of the extent of recession, and they will say, because it's a phase 3 study, this is the truth. No, we are here also to explain to neuro-oncologists that they are lying for the patients. And we know that because, of course, thanks to the Glioma Consortium in France and many colleagues, especially Joan Palu also, because he did the job more recently published in Brain about 1,500 low-grade glioma. It's not hazardous. We have also 15 years of median survival. So we know that now we can win approximately 10 years from 5, 6 to 15. From 10 to 20, because of course now we have also a prospective study still ongoing, especially speaking about supratotal resectione. So I will not insist about awake mapping, but it will be important, you will see in the so-called right non-dominant hemisphere, because we should preserve the real quality of life of the patient, as thinking about 10 to 20 years in advance, so not just to avoid aphasia and hemiplegia. And you know, it's still true that in my experience, we have less than 1% of severe permanent deficit, with more than 95% of patients still able to work, with also 30% of improvement. And then they will say, yes, but because it's a selection of patients with a best molecular profile. So in fact, this is the reason why they are living longer. No. We demonstrated that it was not related to the molecular profile. But Iacola also revisited his first paper in the last one by demonstrating that the impact he had on the natural history of the disease, speaking about not PFS, which does not exist, but the median survival, is not related to the molecular profile of the low-grade glioma. And EANO recommendation, they are telling the reverse. Suddenly, they had a problem with PubMed probably, and they were not able to extract the paper by Iacola. Strange. So we know that now I'm very happy you can reproduce this kind of data, and not just in San Francisco or in Montpellier, because you are here, and more you are publishing many papers with exactly the same extent of resolution or the same quality of life, especially Philippe de Wittemer will speak about not the meta-analysis but the experience in Insula, and I am more or less obsolete now because you can remove more than me with best results. So that's fine, because that means that plasticity exists and that it's not just related to one individual, but related to the fact that it's just common sense. The problem is that, nonetheless, that sometimes we have this kind of disease also with infiltration. But I'm not anxious anymore about gliomatosis now because it does not exist according to the new classification. So finally, we cured them. So I'm not afraid anymore about this kind of scenario because definitely now they decided that it does not exist. It's totally crazy. Speaking about the diffuse low-grade glioma, non-gliomatosis-like, Johan demonstrated that, of course, as demonstrated just before by Pat Kelly, but especially in high-grade glioma, that you have tumor cells far beyond the FLAIR MRI. And this is the reason why you know that I don't like intraoperative MRI, because this is not the truth, because the FLAIR abnormality is not the disease. And 90% of neurosurgeons would like to believe on the fact that what we should remove is a ball within the brain, and of course you have understood that it's a chronic disease invading the brain, and you should remove a part of the brain itself and doing maybe a lobectomy. So according to functional boundaries, and the philosophy is reversed. But the problem is that we have also some financial issues when you start to say, I have a beautiful intraoperative MRI. It's never said, but I will say that. I know that, in fact, the problem is technical, financial, marketing issues. And never it was demonstrated in the literature that using this new technology, you can improve the quality of life and, or at least to decrease the post-operative permanent deficit and to increase the extent of resolution. Never. But in the meta-analysis did by Philippe de Wittemer about intraoperative mapping, it was demonstrated. We have the proof, and it costs nothing. This is, in fact, a problem. Because it costs nothing, it's not so exciting for many people. In fact, we changed radically the philosophy by telling we don't need money, we need the participation of the patient in order to accept that we have not the same brain. And then to do this kind of resection, because we have, unfortunately, tumoral cells beyond what we can see on MRI, by preserving the quality of life thanks to intraoperative collaboration, not just speaking about language in the left hemisphere, but also many functions in the so-called right non-dominant hemisphere. And it does not mean that you should not use your navigation, DTF, MRI, intraoperative MRI, microscope, electrocardiography, blah, blah, but it means that you can do that without any methodology except your knowledge of the brain, the confirmation of line thanks to the collaboration with the patient, intraoperative mapping, and the most important, a very good team. And suddenly, we demonstrated that you can change radically natural history of the disease by removing more tumor, more disease beyond the FLAIR in comparison with just a total resection, and that in this subseries, and it continues to be true with more follow-up, the rate of anaplastic transformation is 0. This is the reason why, now 1 year ago, we published the results regarding the long-term follow-up with patients with more than 8 years of follow-up, from 8 to now 18, because in fact, plus 1.5, and no death, no malignant transformation, no radiotherapy, preservation of quality of life, and no seizures. Remember, seizures limitation of brain plasticity. So if you do this kind of surgery earlier, then you can remove more and you can preserve the quality of life. It's not incompatible. And it's true also, I spoke about the heterogeneity, not recognized by the WHO classification. It's true when you have some foci of anaplastic transformation, not just microscopically speaking, but macroscopically speaking, as you can see here. I would like to report this series, but it's very difficult today because you don't know exactly how to convince referees in a journal who will say, in fact, you did not really apply the concept of the new classification. Yes, of course, because in the new classification, like in the old one, you have this concept of heterogeneity. In other words, for now, and according to the guidelines, this is a grade 3 glioma. Nonetheless, I have many patients with grade 3 and sometimes glioblastoma in the middle with no chemo, no radiotherapy, with the concept of supratotal removal. And what happened? Nothing. The natural history of the disease is just a natural history of grade 2 diffuse low-grade glioma. So we can change radically the natural history of the disease if we arrive just before the explosion of the tumor by removing some foci of malignant transformation, and the clonal concept will make everything as an evidence. I mean, if you have the chance to remove the wrong clone, if I can say, probably Emmanuel will speak about that better than me, but you can arrive once again earlier and to avoid the explosion of the tumor without chemoradiotherapy, at least initially. Johan demonstrated also that if you remove more, it's better for the quality of life. Why? Because seizures are not related to the middle of the tumor, the core of the tumor, but the periphery, the interactions between the cortex and the infiltration. So everything is linked. If you arrive earlier, you will increase the rate of supratotal removal. You will change radically in the natural history of the tumor, speaking about diffuse low-grade glioma or even high-grade glioma according to the classification, if we don't take into account the heterogeneity, and you will decrease the rate of seizures or even just to avoid seizure before the limitation of brain plasticity. You see, everything is just an evidence. So because it's an evidence, that means that sometimes you can remove more tumor. I did that just this week in a patient who had seizures for 1 year. 1 year. She was followed in another institution, stable tumor. And of course, I demonstrated it was not difficult. You can do that by yourself, that the tumor doubled in 1 year. And during this year, the patient had 3 seizures a day despite 2 antiepileptic drugs. But in fact, there were no invasions of the hippocampus, just a paralimbic tumor. And what I did is to remove the mesiotemporal structures. After 4 days, of course, I need more for that, but I did that past Monday, 0 seizures. Suddenly, you can change radically the natural history of the disease. You will tell me, yes, but the cognitive impact. No, she had neuropsychological examination objectively done by a neuropsychologist, but with a PhD in cognitive neuroscience, high level. 3 days after, he told me she's better. I know it's difficult to believe for something, but sometimes you remove the brain and you are better. And it's true. So the question is how to increase this kind of patients in this subpopulation with supratotal removal, impact for the long-term follow-up, and not just speaking about 15 years of median survival, but maybe, as said by Emmanuel, to cure them in some cases, and without inducing any permanent deficit or even by improving their quality of life. And then, of course, incidental diffuse low-grade glioma. I will not insist about a different reason which can make this diagnosis possible. But I was so surprised in my experience to see that you can have just 2 cc, which seems normal, but sometimes 140 cc. Of course, this is the most impressive tumor I removed in incidental discovery. So that means that mechanisms of plasticity are not the same for one patient to another one, because sometimes, of course, you can have a very big invasion without any symptoms. Nonetheless, when we did the preoperative neuropsychological examination, you will see that they had deficit. Once again, there is no stable tumor, even in incidental diffuse low-grade glioma, and insist on this point because this is the question more and more when we speak about the screening. Yes, but you will not remove an imaging. Of course, we are not completely crazy. We will do, once again, another MRI. And what will happen if it's a tumor, the tumor will grow. Then you will calculate the growth rate, and you will say, this is the tumor. It's not a vascular or inflammatory disease with 2 to 4 millimeters of mean diameter a year. We have the diagnosis. No, the diagnosis is histopathologic. Please give me another example with this kind of growth rate. Yes, but we need histopathology. Okay, perfect. We will do the surgery. Finally, you see, we agree. If you do preoperative neuropsychological assessment, thank you, Jérôme, it demonstrated that finally, in 50% of cases, 60 sometimes if we take into account the subjectivity of the patient, which is absolutely crucial, they already have some deficit before any symptoms, before seizures, before the limitation of brain plasticity. And this is due to the infiltration of the vibrator tract, as we said before. So everything is linked. And we should apply the same reasoning, the same concept to this patient before any symptoms. And what happened? They can become malignant, but also glioblastoma, suddenly. And without any symptoms, I mean no deficit, visible, neurological, according to the neurological examination, but before any seizures also. So the concept, the dogma is, please wait at least the first seizures because you are protected from malignant transformation before the epilepsy is totally wrong. You can have a sudden explosion, an acute glioblastoma transformation in a patient with no symptoms. So we are not protected. So please remove the tumor because in this case, the patient was referred too late. Of course, I did the surgery, but it was a glioblastoma. In the depth, it's not possible to do supratotal resection anymore, while it was possible initially. But 3 years before, according to another team, it was too dangerous to operate. Yes, but they killed the patient by doing nothing. I will say again, they killed the patient. So now we had first preliminary experiences with 70 patients, incidental diffuse low-grade glioma, and what happened, smaller tumor, so 30% of supratotal resection independently of the molecular biology. So that means that suddenly you can do in 1/3 of cases a supratotal removal, plus in 1/3 of cases a complete removal, plus in 1/3 subtotal removal. So the rate of partial removal less than, than 10 to 15 cc according to Michberger, Nader Saneh, according to Worlds more recently, is 0. It makes sense because we arrived earlier, except in some gliomatosis like tumor, as I showed you. No epilepsy, except in 2 cases transitorily when they decided to not take anti-epileptic drugs. I love when a neurologist explained to me that we have not to treat patients with anti-epileptic drugs following surgery because no recommendation. Yes, but in 2 cases, they say, I don't want, they had seizures because it's a surgery. So recommendations, we don't care. We should adapt to each patient. Nonetheless, in all cases, it was possible to have, after 3 months, no seizures anymore, and of course, a return to a normal life in 100% of cases. So everything now is linked with what was said previously by Emmanuel. When to arrive earlier and earlier and earlier, before any symptoms, and to better understand also the natural history and the pathogenesis of diffuse low-grade glioma. And then we have asked to people, because ethically it was important, do you want to benefit from screening? Once again, in 2/3 they say yes, and it's just an evidence. No. I will try to define what means quaternary department. Because we have understood that it's not so complex to do earlier MRI, if the possible patient agrees, Because we have understood that we should remove more and earlier, the question is finally, yes, but is it possible to remove with a high level of reliability the brain and not really a very big tumor if we are speaking of incidental discovery low-grade glioma? And to do that, definitely, we should know the functional anatomy of the brain. And very quickly, I would just say that if speaking about movement, we cannot just avoid hemiplegia, but to preserve the bimanual coordination, for instance, for a pianist or a sportsman. We spoke about that yesterday, and more, I am happy to see that finally, in many countries, in many departments, Broca's area does not exist, and you can remove the left inferior frontal gyrus. We speak about that in the second talk, and the transopercular approach in the left dominant hemisphere to go to the insula. But the goal is not just to say you can remove the left inferior frontal gyrus. The goal is to say we should see the networking processing of the brain, and suddenly you can remove more by improving the quality of life of the patient, even in incidental discovery diffuse low-grade glioma, because in 60% of cases, the preoperative neuropsychological assessment is not normal. So it's completely crazy. So you can remove the lobe, and the patient was well before, but it's better now. Yes, except for something, once again, but I have the proof, objectively. Of course, we can adapt to the quality of life of the patient, just of course, but it's never done, exceptionally, and just in this network. But we are here in order to convince other people that they should take care about the quality of life of the patient by taking time before to go to the operating theater and telling, please tell me what means your quality of life. And not just to avoid hemiplegia and aphasia, of course, but it's not enough. And according to that, each year we can learn a little bit more about the brain. And this year we learned about the fact that we started to understand relationships between oculomotor saccades and attentional processing, which is absolutely crucial, of course, in order to enjoy normal life, because I don't know for you, but my problem continues to have patients in general, diffuse low-grade glioma, tired due to attentional deficit and working memory deficit also. So they can do everything normally, but by increasing the cognitive cost related to the fact that it should be a little bit more attentive, as I do when I speak English, for instance. So at the end of the day, I'm more tired rather than to do the same thing in French. We have understood more or less also, just at the start, of course, and that the ventral semantic stream is involved not only in the semantics of language, but also the non-verbal semantics. And definitely it's absolutely crucial, but it's difficult to make this understandable to 90% of neurosurgeons. So we should push a little bit more, and it's exactly what we did recently by demonstrating that the right non-dominant hemisphere and the ventral stream is absolutely crucial, at least in some patients, because I agree with Philippe, sometimes you can cut it and to have a compensation, but sometimes no. So the question is how to predict that in this patient at this moment, speaking about incidental discovery when you should preserve a perfect normal life. And today, I'm not able to predict that before surgery. So I prefer to wait, to stimulate, and to say, if I find modification of the semantic association task, I will stop according to the right inferior fronto-occipital fascicle. But it's not enough, because now I become older, and I have the habit to say that, but it's true. And the problem is that I start to understand that cognition is absolutely crucial, but the most important in human being is emotion. So we should start to understand not only emotional processing by itself, but the relationships between the action, and not just the movement, the cognition, and not just executive function, and the emotional processing. And this is exactly what we started to do a couple of years before, 3-4 years before, by testing mentalizing into the operating theater because it's very frequent, at least in France, that some patients are telling me, I would like to preserve my capacity to be the same. My personality should be the same, not only for myself, but for the family and for my environment, speaking about socio-professional life, which is normal, especially, of course, in incidental discovery low-grade glioma. And then we started to understand, I already showed this slide, but now we will add something more, that you have a first level of mentalizing, which is to better understand, to perceive the emotion of people in front of you, so underlain more or less by the superior longitudinal fascicle, but higher level, which is to attribute the intention of others. So underlain by the cingulate bilaterally, and more or less maybe the default network involved also in creativity and meditation, for instance, just examples. But in fact, now we published recently a paper showing that the semantic ventral stream is also involved, including in so-called right non-dominant hemisphere, in the semantics of emotion, semantics of theory of mind, of empathy. So in fact, 3 levels. And if you do these tasks into the operating theater, I can induce modification sometimes during the mentalizing task while the PPTT is preserved when I stimulate the IFOF. And the reverse. In other words, I was not so sensitive enough 2 years ago. So the question will be, is it absolutely crucial to preserve it? I don't know today, but I know that before doing that, my neuropsychologist demonstrated that at least in 15% of cases, by not doing awake surgery earlier in my experience, because patients are living longer and longer, they had permanent modification of their personality. So to me, it's absolutely crucial to understand that by speaking about supratotal removal in patients with incidental discovery and a fortiori screening. Otherwise, we cannot say to the patient, I promise you will be okay. I promise you will not be hemiplegic. Is it enough for the patient? And now we are more and more connected to the mechanisms underlying consciousness, and of course, not just one network, but the metacognition, consciousness of yourself, the consciousness of the environment, spatial awareness, and so on and so on. I will not insist about that, but it's very important to be able to explain that to the patient because, once again, at least in France, but they are very frequently asking this kind of question. Are you sure that you will not change my personality? And not just to avoid aphasia, hemiplegia, I have understood, I trust you, blah, blah, there is a tumor, it's growing, I feel well, so I agree, you can remove as much as you can. But what about the emotional process? It's 80% of my questions now. I don't know for you, but incidental discovery. So we published voluntarily in World Neurosurgery and not in Cortex or Human Brain Mapping this new diagram about the processing functional anatomy of the right non-dominant hemisphere, just to show to neurosurgeons that in the right non-dominant hemisphere there is not just Rolandic area. And then you can do what you want, and you can weight according to the philosophy of your team and your patients. And of course, this is not a Bible. I hope you will participate in increasing this understanding in the so-called right non-dominant hemisphere, and of course, the connectivity with the left dominant hemisphere. About plasticity, if you operate, reoperate, and so on, you can change not now natural history of the disease, but you can change also the brain reactivity by removing then the second time the knob of the hand, but also in this case, for instance, the Broca's area. I showed this case because incidental discovery by a radiologist himself because headaches. And finally, I was not able to remove completely Broca's area the first time, and the second time it was possible. And the guy is, of course, enjoying a perfect normal life, a running marathon, and still radiologist. So typically, this is an illustration of the topic of diffuse low-grade glioma incidentally discovered. or in this case, left temporal resection initially. I was so disappointed, and 10 years after, it was possible to remove more without inducing any permanent deficit. So, in other words, what means eloquent areas? Because more and more, I have this problem too. Okay, we are convinced we should remove the tumor earlier. It's possible to do supratotal removal in this case, probably because the tumor is small, but located in Broca's area. So I cannot remove this tumor. Why? Because the guy is young. Yes, so the plasticity is optimal. Please go to the OR and you will change radically in the natural history of the disease. No, a priori. A priori is the weight of history, the dogma, localizationism. In fact, it does not exist, fortunately. So once again, now the goal is to make the link between the left dominant hemisphere, the right non-dominant, because it's a whole brain. It's so evident that it's never said in neurosurgery, because we will continue to say, I will take my neuronavigation and to be into the contact of the Rolandic system, the Wernicke area, the left dominant hemisphere, so awake surgery, the right non-dominant hemisphere under general anesthesia. So dogmas in so many meetings, I cannot understand that. No plasticity in neurosurgeons. So we have limitations of plasticity, of course, and we published this atlas 1 year ago. By demonstrating that when you are into the consultation, you see a patient for the first time, you don't need DTI, fMRI, blah, blah, if you can do that. But just with your mental imagery, you can finally say to the patient, I will remove approximately 80, 90, 100, or 120% of the tumor. And it works very well, at least with a reliability around 90% of cases, and I can show that because for a couple of years I decided to put this score a priori into my report when I saw the patient in consultation. And then you can compare to the post-operative MRI, and I think that Mitch did exactly the same thing. We had a discussion in Los Angeles a couple of weeks before, and he told me that he had more than 90% of reliability. So just with your mental imagery, which is normal. But it's not enough, because if you leave the tumor migrating too much, because Fabien demonstrated that, in fact, you will have a decrease of brain plasticity by invading the connectivity, you can start to know if the patient will recover following surgery, not according to the lobectomy you will do, but according to the fact that there is already an invasion of subcortical connectivity, for instance, in this case, the IFOF. I mean, we published with Emmanuel 10 years ago in Brain that it was possible to do a left temporal lobectomy by cutting the anterior part of the inferior longitudinal fascicle with a perfect recovery. In fact, we were wrong. I mean, if you do a naming task, that's true. But if you now do the reaction time, they increased. So it's not perfect. Once again, the patient can decide also to have a more extensive resection and finally to have some difficulties to find words. I mean, with an increase of reaction time and not anomia. But you should explain before. And it's related to the fact that you have already an invasion of the inferior fronto-occipital fascicle, the direct ventral semantic pathway, or not. So when neurologists, oncologists are telling, oh, the patient is well. No, please do a preoperative neuropsychological assessment. He's not well. The patient has no seizures. Okay, perfect. So the volume is still low. Okay, small. But in fact, they cannot see that you started to have an invasion of the IFOF, and as neurosurgeon, you are telling just for 2 cc more, I will not be able to do a complete resection, and a fortiori not a supratotal resection anymore. So it's too bad, because it was possible initially. So please anticipate that also, and not just look at the volume. So the take-home message is that, of course, a supramaximal resection has a significant impact on the natural history of the disease, and I would like to believe that maybe I cured some patient. I'm sure that Lorenzo will show more or less the same results now by demonstrating that you can change radically the natural history of the disease with good quality of life, also sometimes improvement of the neuropsychological assessment. So the question is still the same, how to increase the rate of supratotal removal, of course, to diagnose earlier, and of course, the screening. So I will not insist about what was said by Emmanuel, but just to say that we present this project to the National Academy of Medicine 2 months ago altogether with Luc Taillandier, our neuro-oncologist in Nancy too, and the past president of the Neuro-Oncological Network in France. And they said finally, yes. I mean, ethically speaking, medically speaking, we have some maybe administrative and financial issues to solve, but the most important, at least to me, was first of all to know if the Society of Wisdom in Medical Association in France agreed with this proposal. And the answer is yes. My problem, nonetheless, just to conclude, is maybe to introduce what we will speak about regarding the new EANO recommendation. And I would like to thank now our Greek colleague, because they invited me 2 months ago in Larissa, and I was very happy because this is the city where Hippocrates died. And finally, I had a more philosophical view about this problem between the technology and the genomic and the evidence-based medicine, but just based on recommendation, the medicine of protocol, versus what we say today. I mean, to adapt to each patient and to give the choice. And the problem is that in oncology, as you know, in 95% papers, especially in Lancet Oncology, JCO, New England, and so on, the most important part is just to have a p-value significant and to demonstrate that you increase the overall survival. That's it. Yes, but after 10 to 20 years, maybe it's important now also to ask to the patient, what do you want for the next 10 to 20 years? We are not speaking about glioblastoma anymore. And it's never done. I mean, your quality of life regarding what you would like to do for the job, for the hobbies, for the family, for maybe to buy a house. So with anticipation, 1 generation before. And we can start to do that with the patient in consultation during the first meeting, especially in diffuse low-grade glioma with incidental discovery, and especially if we would like to achieve a supratotal removal. So not just the median survival. But in the new classifications and new recommendations, you can read the new Lancet Oncology, quality of life, there is nothing. Just everything will be based on 1p90q, IDH1 mutated, TERT, and so on. And according to that, we will decide for you what we should do or not. It's completely crazy. It's not in agreement with the principle of Hippocrates, at least to my opinion. No. It's not in agreement with the principle of Hippocrates, and to my opinion, we should also fight against the medicine of protocol to adapt to each patient. And they would like to make us explain to us that this is a tailored medicine based on the molecular pattern of the tumor, rather than to look at the patient and to ask the needs, the wishes of the patient and the family. I think that we have a problem to solve. And the problem is just to say, do you want to see the molecular pattern of a tumor in order to treat the glioma, or do you want to adapt your management? And sometimes maybe by doing nothing, the patient is telling, I'm not ready to benefit from a surgery. Now, even if I have understood cognitively speaking the rationale, but emotionally, I'm not yet ready to adapt to each patient at the individual level based on the Hippocrates oath. I have solved this problem for me, but I know that in the young generation, it will become a real problem, a real issue, because sometimes you will have to fight against the recommendation in order to provide the best for the patient based on what we know today. So I hope we will help the young generation through this kind of networks in order to protect you and to be in agreement not only with the patients, but with yourself. Thank you very much.